Hello and welcome to this month's ERJ Podcast. My name is James Chalmers and I'm the Chief Editor of the European Respiratory Journal. And I'm really delighted to be joined today by Stephen Walker. Stephen's from Bristol in the UK, and we're going to be talking about a new guideline. We love a guideline on the ERJ Podcast. We're going to be talking about a new guideline, the Clinical Practice Guidelines on Adults with Spontaneous Pneumothorax. So welcome, Steve.
Thank you, and thank you for the kind introduction, and thank you for allowing me to talk about these exciting guidelines.
So let's jump right into it and talk about what the main recommendations are. So this is a joint guideline with 3 societies and a number of recommendations. So walk us through what you want us to do with spontaneous pneumothorax.
Yeah, so with these guidelines, and as you say, it was a joint endeavour with 12 clinicians, respiratory doctors, and 12 thoracic surgeons. And we've made 12 key clinical recommendations and answered 12 key questions, which we think are the most pressing ones for spontaneous pneumothorax. And for each of these questions, we've addressed both primary and secondary. So we've covered quite a lot of ground within this. Now, the first 4 recommendations were about the initial presentation of pneumothorax. What do you do when you see a patient in the emergency department with a spontaneous pneumothorax? The following 3 recommendations is that really challenging situation about what you do with a persistent air leak, those patients that are on your ward with a chest drain in situ who are bubbling away, and how we can help decrease the duration of that air leak. And then the final 2 PICO questions are about recurrence preventions, and those are really focused on elective surgical techniques. And then that's followed by 3 narrative questions, which are very much about more patient-centered things about predicting outcomes and selection for surgery, and some lifestyle questions, which are very important to patients.
Yeah, so one of the key recommendations is around conservative management of spontaneous pneumothorax. So the panel suggested that in selective cases, regardless of the size of the pneumothorax can be managed conservatively if individuals are minimally symptomatic. So the 2 points I wanted to pick up with you there is what is minimally symptomatic? Sort of what's the thinking behind that recommendation?
Yeah, I think you picked on one of the key changes and key recommendations of the guideline, because that's quite a move away from the very interventional approach that we've historically managed spontaneous pneumothorax. So conservative or an observational approach is quite a sea change from how we approached it. And that's really based on new evidence over the last 5 years, particularly one of the landmark trials, which was an Australian trial, which was conducted and published in the New England Journal around 2020. And that was looking at 316 patients with moderate to large pneumothorax and randomizing them in between a conservative care or an interventional approach with a small bore chest drain. And that was a positive trial in a variety of outcomes. And so that's why we've made that recommendation. But it is a conditional recommendation. And you've picked up on one of those conditions. And one of those conditions is that those patients are minimally symptomatic. Now, while that paper didn't look out to sort of select minimally symptomatic patients explicitly, the patient population they ended up getting was a very minimally symptomatic patient population. So if you look at the breathlessness symptoms, which was measured on the Borg score, they were about a 1 out of 10 on the Borg score. If you look at pain scores, which are again measured on a 0 to 10 score, it was about 2 out of 10 on a pain score. And if you look at other clinical trials that did symptom scores, this seems to be, though it's hard to compare, a less symptomatic patient population than you might expect for patients with primary spontaneous pneumothorax. So the recommendations are based on the cohort of patients that we had evidence for. But the main thing to say, really, and I think you've highlighted this, and the sea change is that we're not basing decisions based on the X-ray. We're not basing the decision based on how large the pneumothorax is on the X-ray. You're basing it on the patient in front of you. You're basing it on the degree of the symptoms. And, whilst symptoms are very objective, a very good rule by some is whether these patients can comfortably mobilize around your emergency department. And also, we just want to make sure that these patients are clinically stable, that they haven't got any sort of signs of physiological compromise that would necessitate an intervention. So very much a more patient-focused and patient-centered approach as opposed to a radiographic approach.
Yeah, but it's tricky, isn't it? Because most people coming to an emergency department, they're not coming to the emergency department for a bit of fun. They'll be coming because they've got symptoms. The pneumothorax will be detected because they've got symptoms. So I get there's potentially a bit of scope for variation in care there in terms of the level of symptoms that people will regard as necessary for intervention.
Yes, completely. And I think between the individual clinician and the individual patient as well, there's going to be variation of care there. And I think what we can do as a guideline society is make recommendations about the evidence we've got and help educate sort of the clinicians and patients about the evidence. I think helpful in this guideline as well is that we've got a decision aid. So we've got a diagram which goes through some of the outcomes, patient-focused outcomes for each of these main initial interventions. And it talks about, duration of hospital stay, recurrence rates, need for repeated procedures. So hopefully with this, we can make a sort of conditional recommendations with a patient input about how best to manage it after a discussion.
Yeah, and I think that's really important. That idea of incorporating the patient's view into this is very important. And you've done that with another of these recommendations. One of the ones that I picked out that I thought was very interesting is PICO number 4. So the panel suggesting early surgical intervention for initial treatment in patients who prioritize recurrence prevention. So the way I see that is it's imagining a conversation with the patient where the patient says, I really don't want this to ever happen again. So I would be interested in discussing surgery. I'd be interested how you currently manage those sorts of discussions with patients and how you envisage that recommendation being implemented.
Yeah, and I think it's important to sort of appreciate that previous recommendations only advocated surgery for patients who'd had more than one pneumothorax, who were on the second or third pneumothorax. And this is about having surgery at your initial presentation. And so that is quite a shift. We know, and this is part of the explanation to patients, that around 25 to 30% of patients with a primary spontaneous pneumothorax will have another pneumothorax. But we also, the converse is also true that, the vast majority, 70% of them won't go on to have another pneumothorax. And that's really where the basis of the previous guidance has come from. But what these trials have showed, and one of the largest of them was the Olsen trial showed, is, and I get this isn't a massive surprise, but if you do intervene on these patients surgically at the onset, then you can dramatically decrease the rates of recurrence without increasing the rates of hospital stay. And there was some cost effectiveness with that as well. So the way I would approach it with a patient is really talk about surgery as an option. But for the vast majority of patients, we're not pushing for a surgical approach at the first line because most patients won't have a recurrence. And using that Olsen data, you can say that 5 patients who will have to undergo a surgical procedure to avoid one recurrence. So we know a number to treat there of how many operations we need to prevent a recurrence. But what this allows us to do is, again, a very patient-focused approach of if a patient, for whatever reason, really found their whole experience, as you described, incredibly uncomfortable or very psychologically distressing, and some of these patients really are young patients, really struggle with the idea that this may happen out of the blue again. And for those patients, or in patients with certain occupations, which mean that a surgical operation should be advocated, then this allows us to make a conditional recommendation that surgery should be thought about. The only additional thing to say is that either way, having a pneumothorax should be a teachable moment. We know that most patients who have a pneumothorax are smokers, and we know that stopping smoking can dramatically decrease the recurrence rates of having a future recurrence, and that's described in one of the narrative questions. So whether you're advocating for surgical approach or a non-surgical approach, we know that stopping smoking will further reduce their chance of recurrence.
And that's great. A simple thing to emphasize. So we've talked about a couple of recommendations there that represent a significant change from what's been recommended in the past. Are there any other recommendations you would particularly highlight as being new or potentially impactful?
ambulatory management of primary spontaneous pneumothorax. I think that is new. Ambulatory approach to pneumothorax has been around since the 70s, but there hasn't been any randomized evidence supporting an ambulatory approach. And what we mean by an ambulatory approach is using a device, usually a one-way device that allows air out without allowing air back in, that isn't an underwater seal. So these patients can go home whilst the pneumothorax is being managed. And there has been one large trial, the RAMP trial, which showed that using an ambulatory device led to much shorter lengths of hospital stays than the standard of care. And so I think that is quite an exciting new way of potentially managing patients with primary spontaneous pneumothorax who are symptomatic, who do need an intervention, but don't particularly want to stay in hospital because they're young and they would rather minimize a length of hospital stay. The only caveat to that really, and it's the same with conservative management as well, is what we're describing are pathways that need support and infrastructure. So if you're sending someone home with an ambulatory device, your hospital or your unit needs the infrastructure to be able to review those patients in an ambulatory fashion. So you need an equivalent of an ambulatory clinic to make sure that those patients are, that they're responding appropriately to their ambulatory device and also to remove their ambulatory device as appropriate. And I think that's important to recognize that it isn't just the device that matters, it's the whole infrastructure.
It's great to see so much new information coming from randomized controlled trials. I mean, it's a credit to the plural research community that you've got so much new evidence that you can incorporate into these guidelines. And it is creating a step change in how we manage pneumothorax. So really, really fantastic to see. So thanks very much, Steve, for walking us through a primer on the new guidelines. The guidelines will be online this month in the European Respiratory Journal for everybody to read. Congratulations to you and the panel for putting that together. I know what a huge amount of work putting together a guideline over a 2-year task force can be. And thanks so much for speaking to us today on the podcast.
My pleasure. And thank you again for the invite.
So thanks for joining us for this podcast on spontaneous pneumothorax. We'll be back next month highlighting another major paper published in the European Respiratory Journal. Look forward to speaking to you then. Bye-bye.